We are on now.
Yes.
That's wonderful. Good morning. Hello to this event. I am Pernille Weiss, and I'm so happy to see all of you, all that I can see here in the room in Maastricht, but also all and the many more you are out there online participating. It's a very big pleasure to be here together with you. Yes, I am Pernille, as I said. I come from the European Parliament. I'm a member of the European Parliament. But I'm also a Dane, and I'm also a nurse, and I also have some other educations within health. So I'm so happy also to be chairing the intergroup of obesity and health resilience in the European Parliament, because what we really need to do better in the European Union is to go by our own example in how to change both the narrative and the understanding of how serious and important it is to do better in combating obesity. So thank you for being here together with me and also Jacqueline. Yeah, I know you're Jacqueline. But my card doesn't say that I am supposed to introduce you right now, but I will do. Let's do it a little informal. We are post-COVID now, so let's make this online event feel a little bit more tactile. So thank you for joining me, Jacqueline, from all the way from Uganda.
From Uganda.
Yes, yeah. I'm so delighted.
Yeah.
Thank you so much.
Yeah.
Now, the objectives of this event here is how we can actually enable impact policy change, because the session needs us to be better to understand how we can change the approach to obesity, but also how we can actually change the attitudes towards obesity. And what is better to make progress in that is actually to learn from others who did the walk before we are now speeding up going forward. So we will hear from colleagues from obesity space to explore how the lessons and the themes of the session we are going through will work. But before we do that, we will hear from the other diagnosis groups and strong advocates that can help us to understand how to improve policies and build better health system resilience. I think this way of also reaching out to others than the group we are, we can also co-create much better for a coherent, unified way of supporting health in the future. So that will be the objective of this morning session, and I will now go forward to the housekeeping rules that of course also are here in the house and virtually. And I will turn myself to the screen, and maybe we can then see. Whoop, 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 whoop. Whoop, boy, it's going fast. Yeah, we could jump to conclusion. Yeah, we will meet Sylvia Friedman and Jacqueline Alesi, and that was you. Thank you. And so Sophie Corlett from the External Relations from Mind. You are coming from U equals U, Global Community Leadership, Jacqueline.
I'm actually coming from Prevention Access Campaign.
Ah, okay. Yeah, interesting. We will hear more about that
Exactly.
in the moment. Thank you so much for being here. The housekeeping, is there a slide on that? There is. Okay, so then there are actually no housekeeping rules. It will be an anarchy for this morning. It's going to be so interesting to see where it takes us.
Yeah.
Okay. COVID have put the spotlight on a lot of health inequalities, especially for certain groups and especially for people living with obesity. And I just talked yesterday with a colleague in the European Parliament, and it is so clear for me that we really have a big work to do in also to educate more of our colleagues about the serious threats to health and life that are around people suffering from severe obesity and also predispositions to obesity. Politicians are actually, my colleagues are actually not in the extent that is needed aware about that. So that is one of the very big issues and goals we have in front of us to succeed on that. Also, learning from post-corona, we need to build back better and ensure that we have, both in the European Union and by the way we do it, a health system resilience that better serves the communities, especially for people suffering from severe obesities, as well as also their families. We must not forget them also as a part of the context. And then in the near relationships to the citizens with obesity. We need to act quickly because we don't know when the next health crisis, the next maybe pandemic, will meet us again. So also for sure we need that. We need to understand that the future is uncertain, and that we need to also to act more accelerated and more confident. And what to do that, we need also to be better, to have an open discussion and an agility with each other to understand precisely how we can do good and react effectively whenever needed in a future where we actually really don't know what can hit us, especially when it comes to health. So the key priority for us is to ensure both at a national level and the EU level, and that is one of the big objects that we are working with right now in the interest group of MEP obesity and health resilience, and that is to convince all member states in the EU and EU together to treat obesity as a non-communicable disease, as any other non-communicable disease. And that is really where we can push the boundaries of understanding what this here is about. So we are conscious about the key barriers. We have learned that throughout the pandemic, and the very many and thank you EASO for that events we have had during the pandemic, talking about this situation, about this challenge that we have, that we don't have a unified way of looking at obesity in the European Union, but also that almost 60% of citizens plus 18 years old in the European Union are actually suffering from severe obesity or predisposals for pre-obesity. So we really need to act on these data and take them very seriously. So what we will do is now to explore how to do what we want and what we must do. And we will do that by examples of success from other communities facing similar issues. And therefore, it is a pleasure for me to introduce the first speaker of this morning. As we saw on the screen before, the picture of Sylvia Friedman. She's a co-founder of EndoActive and has made great strides in Australia to improve the recognition and awareness of endometriosis and increase access to care. I will hand it over to you, Sylvia, to present what you have as messages for us this morning. Sylvia, are you with us? Yeah, I see you there. Hi.
Yes. Hi, can you hear me okay?
Yes, it's perfect.
Okay, brilliant. So thank you so much for having me. As you said, my name is Syl Friedman. I'm co-founder of EndoActive, and I'm a passionate advocate and health educator. So again, thank you for having me. I so wish I was over there in Holland with you all, but I'm joining you from Sydney, Australia. And before I begin, I would just like to acknowledge the traditional owners of the country on which we meet today, the Gadigal people of the Eora Nation, and pay our respects to the elders, past, present, and emerging. Australia always was and always will be Aboriginal land. So in the photo that you can see on my first slide, is that up on the screen? Oh, actually, sorry. I'm going to play you this short video first. Oh. Yeah, so I'm just going to play you a short video just to preface it. This was taken of about 11 participants, all with endometriosis, or endo as we like to call it, and we screened it at our first medical conference on endo. So I'll let you have a listen.
The thing that I really wish for is a life without fear of pain, without suddenly being disabled.
Have a career where I don't have to call in sick every month. I really want to go back to work.
Part of me wishes for a cure for endo, and the other part of me wishes for awareness of endo starting at the school age.
I wish for all of this to go away and I never had any of this problems, because then I could be able to go to school and spend time with my friends.
I just wish people knew about endo before you told them about it.
I'd like endometriosis to be taken more seriously.
To raise awareness for this.
You gave us the confidence to talk to people about it. Before we were talking only to our friends, but now we make it a point that we talk to our family members, everyone.
Millions of pamphlets for smoking and cancer and stuff. There's nothing on menstruation or endometriosis.
You know, it took me 7 years to see a specialist. So if we can shorten that at all, I think that would be a really good positive.
For doctors to recognise this disease, to take it seriously, and to get help sooner.
For 2 years, I was lost. I had no one to help me with this or help us with this. But EndoActive Australia, New Zealand has given us that confidence to just talk to people. Thanks to you.
Okay, thank you. So if you just hit the next button a couple of times, it should just come up with some other words. Yep, that's enough. Thank you. So in the photo on the slide that you'll see there, you'll notice that I'm holding a document. So that document is actually Australia's first ever National Action Plan for Endometriosis, which was published by the Australian federal government and launched in 2018. So today I'm going to briefly explain to you how EndoActive has been a successful player in the endo space and how several endo organisations came together to successfully lobby the Australian government. So just my next slide, please. Thank you. So just briefly, what is endometriosis? So for those of you who don't know, endometriosis, or endo as we like to call it, is a painful condition affecting 1 in 9 women, girls, and people assigned female at birth. It occurs when tissue similar to the lining of the uterus grows outside of the uterus in places it shouldn't be. And this can often set up pain pathways within the brain and can lead to chronic pain. It often begins to present as debilitating period pain. It can sometimes cause infertility or subfertility, but severe pain is generally the most prominent symptom. And we do start to notice that adolescents at school are missing out on a lot of school due to severe period pain. And what we do know now is that most of those, a lot of those teens will have endometriosis. And so just for the record, getting pregnant or having a baby is not a cure for endometriosis, as some of you may have heard. It's a bit of a medical myth that goes out there. So, and just my next slide, please. Just always like to reiterate that one. So just a little bit about EndoActive. We're an independent not-for-profit. We were founded in 2014 by myself and my mum, Leslie. Essentially, I am an endometriosis patient and she was my carer, and we started to lobby together a couple of years after I was diagnosed. We know that for cultural reasons relating to menstruation, endometriosis has rarely been featured in public discourse until EndoActive actually started, and then we were getting a lot of media attention. We're assisted by a committee of 9, and we believe in and promote evidence-based research. Thank you. Next slide. So that's me. That photo was taken, I think I took it myself when I was in hospital. I was diagnosed with endometriosis at age 21. This photo was taken after my second surgery for endo in 2014 and pretty much sums up how I felt about having endo at the time. But it was actually during my recovery from this surgery that my mum, Leslie, and I started to make some noise about the injustices that we were starting to see that people with endometriosis face, which is not something I ever would have imagined when I was sitting in my hospital bed at the time of this photo. Next slide, thank you. So, you know, what we came to realize is that every day, you know, women and people assigned female at birth are turning up to emergency with invisible pelvic pain, but it's severe pain, period pain often, and frequently those people are turned away. They're not taken seriously. Their pain is often dismissed, and often they're actually treated like a drug seeker or an addict. A lot of people don't believe that period pain can be so excruciating, or if they do believe that it can be so painful, they will often say, oh, well, that's just normal. Everyone goes through that. You know, it's nothing to be worthy of going to hospital for. At one of our hospitals in Tasmania, a young woman was told that they don't treat period pain at the hospital she presented to. And in Adelaide, another girl was told that she was too young to have endometriosis, which isn't true. So these are just some of the barriers and the stigmas of having an invisible illness that is associated with period pain, which is something that has been normalised and not taken seriously. Next slide, please. So I'm going to touch on briefly just two of EndoActive's many achievements that I'm really proud of. So the first one is our two medical conferences on endo that we've held. So EndoActive was actually born out of a petition that we launched shortly after that photo of me in hospital. And at the time of the petition, we did get a lot of media attention, a lot of coverage. And at that time, we decided to start a Facebook page, essentially just from our lounge room. We came up with a name, and we were talking essentially 24 hours a day to people who were really, really struggling, people who thought that they were the only person with this condition, and really needed help and support. And at that point, I suppose my mum, Leslie, and I felt really a moral obligation to continue the conversation on endometriosis, which a lot of people were writing to us and said they'd never heard anyone say the word. They never were taught about it at school. They'd never seen it spoken about on TV before, never heard the word on radio. So it was very vindicating and validating for many, many people. So that was the purpose of starting on social media. After that, we decided to hold a medical conference. The special thing about this conference was we actually made it for healthcare professionals and patients, which to us just made sense, but apparently this was quite groundbreaking at the time. Normally patients aren't in the same room as healthcare professionals at these events, but we felt that patients were the ones that really needed to know this information, as there's so much misinformation about endo. So we held our second conference in 2017 called Shared Perspectives on Endometriosis. And at both of those conferences, we filmed the video that was played up the top. We had a lot of those interviews. We filmed every single presenter and we turned those into video publications. Now, at the time, because we didn't have funding ourselves, we were charging a very small fee for people to, like a pay-per-view service. But that's not the model that I was after. I do believe that health information should be free for all patients. So as part of the National Action Plan for Endometriosis, which I'll talk about in a little bit, EndoActive actually received like retrospective funding to publish those 21 videos and make them free for everybody. So those are on YouTube and on our website, which is endoactive.org.au. Next slide, please. So just quickly going back to the conference, one thing I forgot to mention, the reason that this was one of our, was so important in terms of lobbying was it gave us a lot of respect amongst the medical community. What we didn't do is we didn't use our anger to, I suppose, troll and dip into that cancel culture of doctors we didn't think were doing a good job or anything like that. What we did do was we wanted to get healthcare professionals on side with us and work together to make change. And that's really important. I don't think that change is made by being the loudest, angriest voice in the room when it comes to wanting to get the attention of government and people who are important in healthcare. So that, and at the second conference, we actually had 2 politicians come and open the conference for us, Gabe Rotman and Nicole Flint. What was special about them is that one was Liberal and one's Labor, so they came together to form the Parliamentary Friends for Endometriosis, which is a bipartisan collegiate of politicians who were sympathetic to our cause. So that led on to our next step, which was the forming of ACE. So ACE stands for the Australian Coalition for Endometriosis. This group was, so see all those logos that you can see on my slide there. That is basically, those were the founding members of ACE. So it was us and several other pelvic pain organisations, endometriosis charities, researchers, scientists, and that kind of thing, university partners as well. So we essentially decided we all wanted to lobby for a better deal for endometriosis patients. We came all together and were told explicitly by the 2 politicians who opened our conference that we would need to come together as one and only present ideas as a unified voice. They didn't want to hear from any of our groups individually and cause conflict there. So that was our challenge. So essentially what we had to do was put all of our differences and competition aside, which can be tricky in the charity space when there's a lot of different groups under the same, in the same industry, but going for the same pot of money. So we put all of those things aside and came together. We had several meetings, and this is essentially what we came up with. You can see those top 5 priority areas. So our groups all went away and spoke to our followers, largely patients, and asked them, what is it that you guys want us to come and speak to the government about? Like, what's the most important issues that need attention for you? We then amalgamated those into 5 priority areas. The first being our ask, our call to action, which was for endometriosis to be the 10th national health priority area. So then what happened was we came up with a name for ourselves. We decided to meet at an organisation called Health Consumers New South Wales, who represent patients. They had a moderator and helped us come up with our ask. Next slide, please. So once we came up with our name and exactly what we were asking.
Can I jump in, Sylvia?
Yep.
This is Pernille speaking from Maastricht. Can you wrap up a little bit, because
yeah, sure. I'm almost
short of time. I will come back to you when we have questions.
No problem. I'll be 1 minute.
Thank you.
So essentially, this is a photo of all of our groups of ACE meeting at Parliament House for the launch of the Parliamentary Friends group. Now, I delivered an address of those 5 priority areas, telling the politicians what it is that we want. It was a really exciting day. What I didn't realise was that our health minister was actually going to announce that our government would be putting together Australia's first ever national action plan for endometriosis. So it was a huge win, and that's essentially what happened on that day. And just the next slide. That's our plan again. And the last 2 slides were essentially just showing that since 2018, endometriosis has received over $68 million in funding from the federal government. And it's gone to projects like Pep Talk, which is the program I'm involved in right now, educating young teenagers about period pain, pelvic pain, and endometriosis. Thank you.
give Sylvia an applause. Thank you so much. That was very, very inspiring, telling us about something that is not to be seen. It's felt, and it has been a taboo for many, many years. As also that is what we share in common in between endometriosis and obesity. So thank you so much, Sylvia. We will come back to you in a short while. But now it's you, Jacqueline Lindsey. You are a global coordinator to strengthen HIV advocacy and also to strengthen the up-to-date policy on HIV. I very much look forward to hear what you can share with us.
Yeah. Okay, so since I'm in the room, allow me to stand up. Is that okay?
Please.
All right. All right. My name is Jacqueline Alesi. I work with the Prevention Access Campaign as the director, the global director for U=U Global Community Leadership. I am based in Kampala, Uganda, but since Prevention Access Campaign is a global organization, I'm glad that I'm here. So my presentation is very, can I have a seat? All right. So my presentation is going to be talking about a very important campaign or something around HIV that's called U=U. And my next slides, when we talk about U=U, it's basically talking about the undetectable equals untransmissible. And this is basically for persons living with HIV who are on treatment with a viral load that cannot be detected, to their partners or to themselves. And that's around 200 copies, and that's by WHO in the guidelines of WHO. So it's very important to also know what Prevention Access Campaign does. And that's the next slide. Prevention Access Campaign started all the way in 2016, along with international activists, public health officials, and researchers. And the message, we launched the message of U=U and the movement. So this is built on 3 strong pillars. That is science-based consensus. It's also built on to disseminate the widely known U=U message or science, and also to advocate access to quality treatment and care for people living with HIV to stay healthy and prevent new infections. So why is U=U a game changer? The U=U is a game changer because it is something that we would love even persons living with and not with HIV to know about. It improves the quality of life for people living with HIV. It reduces HIV stigma. For those of you who are not in the HIV work, there is what we talk about, the 95-95, and that's the first 95 talks about having people on treatment, and the second one is, the first one is about diagnosis, the second one is on treatment, and the third one is on suppression. So this is the U=U is basically to propel the progress towards the 95-95. And also it supports ending the stigma discriminatory laws globally and practices. It also calls for universal access to treatment, care, and diagnosis. We all know the issues around treatment, care, and other things. So why did we need the U=U campaign? You should note that the U=U is a campaign that is run by activists living with HIV. But it's also very important to note that people living without HIV or people who are not HIV positive need to know this information. And why is this? Because science doesn't have publish. You have to believe me. Science doesn't have publish. And that's why we take it every chance we get, we bring it to you. And also you need to know that HIV stigma is a public health emergency, while U=U is an immediate and effective response. So this is something that we all need to know, whether you're HIV positive or not. So in 2016, when the Prevention Access Campaign came on board, it actually had a U equals U consensus statement that was it's actually ran in the US, and that was the issue. If you'd love to know about this, please do visit our website. All this information is there. Also, you need to know that in 2016, when the campaign started by a Prevention Access Campaign, a lot of people, a lot of voices came up, and these were global voices. It wasn't anything to do by either black, white, or pink. It was global voices, and those are some of the voices. If you need the video, it's on the website. And also, you should note that Prevention Access Campaign is in over 105 countries with over 1,050 networks. So if you see any of your country listed, please do check out where it is actually located in your country, but we are in over 105 countries. So we've also received global endorsements of U equals U, and you would see WHO, PEPFAR, UN, CDC, and UNAIDS. And this is just briefly, the next slides are just going to be showing you what exactly we are talking about, especially the WHO did the endorsement, and they have really been, yeah, just pause a little bit there. It's very important for you to note that when WHO mentions something, it means it is authentic and it has been approved. So U equals U, we are very proud that it's a message that has been approved, and we are very proud to speak about it even in global spaces like now. PEPFAR of recent has actually made it as the one primary, it's one of the primary, I mean, the people-centered prevention that has been mentioned, and it's currently encouraging their COP countries to mention or to include U equals U in their applications. So the current PEPFAR that is running is really, I mean, the current COP is including U equals U for the first time. Yeah, so we've also had national endorsements, and in the US, there's been endorsement in Brazil, CDC, I mean, still in the US, CDC endorsed that. So we have USA, we have all these messages. Please do visit our website. All this is there. Brazil has had the endorsement, China, yeah, Monaco, Canada, Zambia, Kenya, and these are all campaigns. Now, these are campaigns that have happened globally. I'm showing you this to know that this is a global campaign that's happening. Vietnam, we have Ukraine, we have Russia. Sorry, I'm yeah, I guess where we are going. So, so they're together, Russia and Ukraine. So please, it's nothing to do political, but our campaign is a global campaign. We've also had national conferences that are happening globally, and the recent one is the one that happened in India, of U equals U, the 13th National Conference of AIDS Society in India. And a lot of messages were actually publicized. We've had one in Tokyo, and all these are to just help you understand that this is something that is already happening. We've had conferences. My colleague Bruce has been part of presentation conferences in Russia, oh God, in Russia, in Turkey, in the Asian Stigma Forum. It was online, and these are all recent conferences that we are talking about. Yeah, so this was just in Dubai, just last month. Yeah. Now, so the next one should be, yeah, sorry, it's still running around the conferences. It's a lot of information. So yeah, we've also had all these messages. If you see a bus that is moving around and has U equals U, O equals O, K equals K, I equals I, all these are messages that are translated in local languages. We've made sure that messages are actually all translated in local languages, and this is happening all over. So just go on. Yeah, we've also have, this is in Kampala, Uganda, where we held a very big conference and members did a very great job. We've also been in the journals. For example, recently we featured in the AIDS journal, which is just, and the Lancet, and these are all interesting journals that you can always check out. Yeah, so that brings me to the next presentation. And you, because you're also on social media, please, you can always hashtag hashtag you, because you, all of that is out there. I'm trying to make sure that I make this presentation interesting and I don't bore you. So, exactly. So, you equals you. So where do, in the beginning I said you equals you is a win-win. And maybe someone would ask, what do you mean when we say you equals you is a win-win? So you equals you is actually good for personal health and also good for public health. Because originally I informed you that when we talk about you equals you, unless other messages, you equals you is for both the persons living with HIV and the persons not living with HIV. Because at the end of the day, it is a person living with HIV that also needs to protect themselves from a person who is HIV positive. It's nothing to do with only a person who is HIV positive. When we talk about a win-win, we need to make sure that we are doing it together. You don't need to blame. The blame shift needs to go away. So it's not news, it's just not used. This is what you need to know. It's not news, it's just not used. Because like currently, most advocacy is focused on individual health and human rights. Okay, and then the approach may not be effective at moving policymakers and all that. But what needs to be had is you equals you is a win-win and can strengthen advocacy for treatment, care, and services. If we talk about you equals you as everyone, we can really win together. It's nothing to do with persons living with HIV only. The blame needs to be, we need to shift the blame. We need to just accept that you equals you is win-win. Policymakers and other stakeholders will be more receptive of PLHIV policies and advocacy. And also the other thing that we need to create you equals you, win for everyone, and including it in our public health benefits. So when we talk about the you equals you win-win strategy, you need to know that we are talking about very many things. There is an issue of food security. There's an issue of a lot of it. I need to make sure that you can all see that. Can you? Okay, good. Yeah. So, and all this is very possible if we really make sure that the strategy is basically to have treatment literacy, mental health counseling, and everything together so that we are able to increase access and remove barriers to optimal treatment, care, and services. And as I conclude, you need to also note that we can only end the HIV epidemic if you equals you is taken as both a public health issue, a public health message and a personal health. So thank you very much for all of the people who are, endorsing this. We are very grateful for everything that is happening globally. PAC has partners that we really appreciate. We thank the governments that have really endorsed this, but we need to really make it at a global, that every organization that is working for persons living or without living with HIV needs to include you equals you in their messages. And the governments need to integrate, need to increase, need to educate, and need to promote. If we can do these 4 things as every government out there or organizations, then we can be able to say we are at the top of ending the HIV epidemic globally. So thank you very much. And we thank you for listening, and thank you very much.
Thank you so much. That was very, very, very inspiring. also in the terms that sometimes in the EU we have these debates on a one size fits all, but actually here we have an approach that could fit a lot of groups of diagnoses. So thank you so much also for a very inspiring way of presenting your many slides. Thank you. The last speaker is Sophie Corlett, Director of External Relations at Mind. You have led, Sophie, for a long time, the long-term campaign that achieved impressive outcomes in changing public perceptions on mental health. I'm so happy also to know that you are with us online. I hope you can both see and hear us, and that we can see and hear you, so that you can have your 8 minutes of presentation on what we in the environment on obesity can learn from mental health.
Great, thank you very much.
There you are,
lovely
welcome.
to be, oh, yeah, can you hear me?
Yes.
Yeah,
please.
great, lovely to be joining you. I'm talking from our offices in London, and there we are, that's who I am. I'm Sophie Corlett from Mind. We're a mental health charity that operates in England and Wales, and I'm going to be talking to you about how we have tackled the issues of stigma around mental health. First slide, next slide, please. So this is the starting point for mental health. Mind as an organisation is basically in the anti-stigma business. That is what we are here for, to change attitudes that mean that mental health services aren't funded, that people don't get a decent shot at life, that lead to people being discriminated against, not just in health services, but in other services, housing, welfare benefits, discriminated against by their friends and family. It leads to people losing their opportunities and to losing their own self-esteem. When I started, I've been at Mind for 20 years. When I started at Mind in 2002, mental health really wasn't talked much about. We did have people donating money to Mind and companies that would donate money to Mind, but they would say, please don't mention me in your annual report, because I don't want people to associate my company with mental health. I don't want people to know that we employ people with mental health problems. And things have changed dramatically in those 20 years. So for instance, during the pandemic, we had, oh no, not yet, to the next slide. During the pandemic, we had people approaching us to give us money. We have hundreds of celebrities now speaking out regularly about their mental health. Mental health is consistently considered either the top or the second most significant challenge to the National Health Service by the public. We've had significant moments along the way when MPs, members of Parliament, have spoken out about their own mental health, when much loved comedian Stephen Fry was probably one of the first celebrities that spoke out, doing a TV programme about his own bipolar disorder, when the first sports people spoke out, which was later than both of those. We've seen in health services, we've seen a concept of parity of esteem between physical and mental health established in law, not established in practice, but established in law. And the National Health Service in England and now in Wales has invested significantly in services. We are a long way from equality, but we really have shifted that stigma quite significantly. So yes, next slide, please. So in 2007, we established a joint campaign with another organisation, Rethink Mental Illness, which we established in England. It was funded by, initially by Comic Relief and the Community Fund, which is part of the big lottery. Subsequently, it was funded as well by the Department of Health and Social Care. And this ran for from 2007 till 2021. We also have a similar campaign that started in Wales in 2012, and it's similar if different to a campaign that's run by a sister organisation of ours in Scotland, and there are other organisations around the world doing that. We have a UK alliance which runs a single day collectively called Time to Talk Day in February, and we're part of an alliance of similar anti-stigma campaigns across across the world. Our campaign, Time to Change, was was based on the findings of Professor Graham Thornycroft from the Institute of Psychiatry, Psychology and Neuroscience, part of King's College London. And it was from the beginning, it was based on this evidence and understanding. And he broke stigma down into 4 problems. First, the problem of knowledge. That's not knowledge about mental health. So one of the interesting findings is that stigma exists within mental health services and within health services where knowledge is not an issue. In fact, we found that knowledge on its own could increase stigma. And similarly, some of the stats around mental health, so that 1 in 4 people in any one year will have a mental health problem, seemed almost to entrench people in the belief that, oh, well, that I'm definitely the 3 in 4. I'm not the 1 in 4. So there was some of the knowledge and some of the stats could lead to increased othering of people with mental health problems. So the knowledge, that the problem of knowledge was around stigma, that stigma exists and the impact of it. And there were problems of prejudice, which was the second problem, problems of prejudice and attitude. So understanding that that stigma might come from you, from me. Problems with behaviour, that so we needed to take people on a behaviour change journey to act differently, and then to become allies or champions. So one step further than that, to believe that they too can change the world around them. And we recognised that, and Professor Graham Thornycroft had found that you don't have to change these in linear order. So for instance, we've had a smoking ban in the UK for many years now, and we found that you can change people's behaviour and the other 3 issues will follow. So you don't have to start with the problem of knowledge. Next slide, please. So the Time to Change campaign, some of the headings have gone a bit small there, but evidence-based and insights-driven. So we built our campaign right from the beginning on the evidence, working with King's College London. About 10% of the spend of the programme itself was spent on evidence gathering and research of the success of the programme. And we measured people's attitudes, their intended behaviour, and we measured the experience of discrimination as experienced by people with mental health problems. And we had articles in academic journals, the Lancet and British Journal of Psychiatry, towards the end when we'd got a good level of that research. And that research was done for us by King's College London and by different research organisations to make sure that the evidence that we were collecting could in no way be questioned or considered partial, because we felt it was really important not just to secure future funding, but also to actually prove that stigma could be changed, because we see this as a massive issue within the UK, within the world, actually, around mental health. And we didn't want people to just accept it as a given, but to realise that actually attitudes and discrimination could be changed. We also made sure that the programme was absolutely insights driven. So it was set up at all because of people with lived experience of mental health problems telling us that the stigma they experienced was in many cases worse than the mental health problem. So we knew this was something that we had to take on. We had people with lived experience, mental health champions on our senior management group. Every project had its own steering group of lived experience. We had focus groups around all our comms of people with lived experience who told us whether they felt that the comms were appropriate or not. We had regular insights research along the way to make sure that we were reaching our audiences and that people felt that what we were doing was helping rather than hindering. For instance, our insights helped us identify early on who our warm audiences were, and that's where we started. So 25 to 45-year-olds was our initial starting audience. Later, we identified and focused on audiences that we weren't reaching so well. So we identified that we weren't reaching young people so well. So we then focused subsequently on secondary schools. We looked at socioeconomic demographics and identified that C and D demographics we weren't reaching so well. We weren't reaching men so well. We weren't reaching Black and other racialized groups so well. So we targeted those audiences subsequently to make sure that our messages were also reaching them. Next slide, please. We had a real range of activities and we aimed them at the different audiences. So our big social marketing obviously was aimed at everyone, the general public. Went into cinemas everywhere, big billboards on bus stops and on buses. We had Time to Talk Day, which we set up and which is now well established, which is much more aimed at warm audiences, encouraging people to talk about mental health and to talk to friends who they know have mental health problems, to make contact and to chat, just make mental health a normal conversation element. We had our always on elements, which were responding to the media, responding to celebrity disclosures, supporting people who spoke out and endorsing their messages. What we didn't do so much and still don't do is to challenge negative comments by people. And we found that it was mainly counterproductive, but also because actually the movement of people with mental health problems challenged that themselves. And it was better for individual people to do that than for an organisation or a campaign to do that. So that was really interesting, and that building of champions and building of campaigners and empowering people to do that, and not considering this really to be our campaign, but to acknowledging that we were running a campaign within a wider movement of people with mental health problems for whom this was their life, and who would pick up things and would be here, who were here before Mind and Time to Change, who will be here after Mind and after Time to Change. We had lots of community face-to-face activities, human libraries, town centre stalls. So you could take out a book, which would be a person, and ask them any question you like a reference library. That was the human library, really powerful intervention. Lots of things in schools, and a really, really big element of our campaign was in workplaces, encouraging employers to take the Time to Change pledge or the Mind pledge to pledge to change practices within their employment. And Mind has a big workplace wellbeing team as well that has worked very closely with employers and helping them to better support people with mental health problems and to have a much more mentally healthy workplace. And part of that, a really big part of having mentally healthy workplace, is reducing stigma and making sure that people feel able to talk about their mental health. Some of the elements was that it would be always person-led, always story-led, always lived experience-led. It's about people, social contact theory, which basically means that you need to meet somebody with mental health problems either in real life or virtually, but making sure that that's on the same level as you. So not as a helper where you're above and someone is below, but on an equal basis. So the libraries, the town centre stalls, the work within workplaces, we would encourage the chief executive to talk about their own mental health journey. And that was very important because obviously within health services, we don't have an equal relationship, and in fact stigma still persists within health services. And humour, wherever we could, we brought in humour instead of challenge to sort of undermine some of the myths rather than challenging the myths full on. We did initially start talking about myths and myth busting, and we found out that that didn't work so well. So what's been the impact over those 14 years of Time to Change in England? Obviously measured very closely through all that work that we did, all that research that we did. One of the really interesting things, that third bullet point down, by 2016, for the first time ever, we found that the media coverage around mental health, when we counted it up, there was more positive than negative media coverage, which was just a real milestone. And that's something that we're keeping an eye on consistently. And also of the people that worked with us, the increased confidence and empowerment and their own feelings of empowerment around their own mental health was really, really important to us for those people that were involved within the campaign and are still involved within Mind. And people talk about the real credibility of being a Time to Change champion. All our resources are still available. Next slide, please. And you can use those and adapt those. Sorry, just to go back to the Mind's ongoing work. We have adopted much of the findings of what we've done within Time to Change into our ongoing work now that that campaign has closed for lack of funding. For instance, our trustee board is 2/3 people with lived experience. Our staff are 50%, more than 50% people with lived experience, and that has been the case for many years. We develop a lot of insights from people with lived experience. We co-produced our brand, our strategy. Social contact is driven through much of what we do now. Even when we meet with ministers or politicians, we do that with people with lived experience. I'm meeting next week with the Secretary of State for Education, and we're bringing a panel of young people to talk about their experience of mental health within the school system. And the biggest area, next slide please, is probably, or the most impactful area is within our media work, which is fronted by our media volunteers, where we support people to speak up. So this is just one example of that. EastEnders is a very famous long-running soap opera on the BBC. It's been running since 1985, and we've worked with scriptwriters and producers and the actors on that soap over a number of years on a number of different characters who've developed mental health problems and different mental health problems. So on the left is the character Stacey Slater, who developed bipolar disorder a number of years ago, and that was very interesting. The feedback that we got back from GPs was that people were approaching the GP with saying, I think I have what Stacey Slater has, bipolar disorder. That's very significant because traditionally, typically, it takes 10 years for bipolar disorder to be diagnosed because it is misdiagnosed and misunderstood, and people don't recognise it in themselves. The other character there is the character Isaac Baptiste, who's developed psychosis, and again, really important character because he is Black and male, and again, Black men are more likely to enter the mental health system when they're in crisis as opposed to at an earlier point. Next slide, please. So here are some of the findings from Time to Change in terms of what works. Involve people with lived experience in decision making. Make sure that it's personal stories that are shared rather than stats or clinician stories. Work with partners to increase your reach. So we worked with Rethink Mental Illness. Sylvia earlier was talking about how important it is to work with other organisations. We found that absolutely was important so that people don't get mixed messages. And share ownership of the campaign. So our campaign was run by us and Rethink Mental Illness, but our materials were free. We've effectively built a movement around mental health that continues, and that as individual organisations, and as we still work together on campaigning issues with government and whatever, but the movement around mental health much more generally continues. And yeah, a really important just final point is that we always talk about people with mental health problems about being us, not about being other people. We all of us have mental health, and we will all of us have mental health problems at some point, whether that's in the past, in the present, or in the future. Yeah, that's just a couple of links to some of the impact reports from Time to Change, which have some of the details of our the impact that we made over the years. And
so Sophie, can you hear me?
Yes, I can.
This is Pernille speaking. Did you wrap up? Was it that I heard that you were ending your presentation, or can you do it quickly?
No, that was the last slide.
Ah, that's perfect. Because there is so much of value what you are telling us, as also Jacqueline and Sylvia did. But now I have a short couple of questions to all three of you, starting with you, Sophie, because I'm a politician and you are a very, very inspiring and also experienced person within mental health care and how to really push also policymakers to engage and not be afraid of talking about what to do better in mental health care. And we need that also in order to understand how we can do better concerning obesity. What are, in a nutshell, Sophie, the miracle touch that we can use when convincing policymakers to engage and to trust that we can actually make a change if we talk better and more in depth with each other on obesity? What is your best advice for us working with obesity?
Yeah, I think there's probably two things. One is to make sure that people see the urgency of the change, and so personal stories from people about how their lives are affected and how their lives are really limited, in our case by mental health, but also the evidence that we were able to collect that we could make a change, that attitudes could change, and that changing attitudes actually did lead to people's lives being opened up. So I think there, certainly around mental health, there's been a belief that this is really an insoluble issue, and that people who have mental health problems, you know, their lives are over. And actually what we were able to prove was that stigma is what holds people back, and that was something that could be changed, that people's mental health problems are manageable in large part, but stigma is something that they can't control. And actually that has also meant that people have been able to fund mental health problems, which has actually also meant that people's mental health has also improved. So it's been, in that respect, enriching.
Thank you, Sophie. We have to continue in the future talking with you about what your experiences and good advices can be. Thank you so much. I know also that it was announced to you that there would be a second round of questions coming from me. There will not be, because time is running. So I have a question for Jacqueline and Sylvie. And I also want to, and that's why I'm cutting away the prefabbed questions. I would very much like the audience here in the room and also online to ask the questions that you would like to do. I have this catch box with me that Jacqueline has promised to throw at the audience, who will then come with a comment or a question. But before we do that, Jacqueline, you represent both a global approach and a national approach. Can you help us? And that's also what we're trying to do within obesity. So how can we communicate in a consistent way, but also in a way where we are progressive and reach results, not losing time, when we both have to say something in a uniform way, but also to target our messages to every member state. In this setting here inside of the EU, we are 27 member states that has individual competences and ways of dealing with health. How on earth is that possible? What is your, in a nutshell, good advice for us?
Prevention Access Campaign is a global organization. And like I said, my role is the directory global community leadership. So meaning that involves individuals, and those are people that we are working with. So Prevention Access Campaign has two things. It's called a global community board and global collaborative. So how we work and how it has been very easy for us is we've made sure that we've worked with communities of people living with HIV in different countries. I have the pleasure of informing the whole globe that Prevention Access Campaign has a community board of people living with HIV who are championing the message. So it's also something that very many, groups that are working with different diseases and different issues to come up with community boards. And this is how the message can really quickly move. These are communities of persons who are HIV positive. But also we work with networks which are strong in countries. For example, right now we've just been joined by a very great international advocate, which is TAC. So there is a partnership we call TAC-PAC. So TAC is the Treatment Access Coalition, and ours is Prevention Access Campaign. But they are based in South Africa, and it's a very great, organization that is very good of advocates and activists. So it's also important to look around people who have the same vision and work with them, and you can achieve a lot. We're also working with the global network of people living with HIV, the global network of young people living with HIV, and the ICW, which is the International Community Women of Living with HIV, and others. So it's always important when you want to move an issue, you work with people who have the same agenda, but with different group audiences. So it's basically very important to include everyone. I think that's what I can suggest, that it can be very working, very possible, and very implementive. You can do this when you work together with different groups of people.
Splendid. And that actually echoes the success we had a couple of months ago, where we had a study trip in 5 out of 27 EU countries, where there was good input coming in that was the same in all 5 countries, but then there was these specific extra things where we could see excellence also grows, where the focus is more precise. Thank you so much, Jacqueline. Sylvia, now we are back to you in Australia. Can you hear us? Yes, I can see you're smiling, so I presume that you can also hear us. I hope you like my question. That is, how do you present solutions to policymakers, given that, like in obesity, there is no such thing as one size fits all treatments and cure for endometriosis? Do you find either economic impact informations or the personal narratives the most strong tools to open up for a conversation with policymakers? You are unmuted. Can you please press? Yep. Yes.
Definitely personal storytelling, I believe, is the most powerful approach when presenting solutions to policymakers. However, we did feel that the economic argument was an extremely strong one, given the prevalence of endo affecting 1 in 9 women or people assigned female at birth. So we knew that the cost would be large, which was why we actually partnered with Ernst Young, which is an international accounting company, and they collaborated on a cost of endometriosis report, which we published collaboratively. That's it there. And beautiful. The final figure was somewhere around that there's roughly a $9.85 billion economic burden on Australians every single year because of endometriosis. So we did feel that that would be a really strong argument to convince government to obviously want to reduce that economic burden on Australians. However, before we even had a chance to publish the report, we actually already had their attention. And I do believe that that was largely from the huge amount of media awareness publications that we were generating ourselves through user-generated content, but also getting the attention of journalists. And I think the what's the word I'm trying to look for? The thing that we had in our favor regarding the prevalence of endo, obviously it's not a great thing, but when you are trying to approach media, the chances are that the person that gets in touch with you will be affected by endometriosis, whether it's directly or indirectly themselves or somebody in their family in their life. And it makes them want to actually help you to get the word out and raise awareness. That then obviously is getting seen by politicians who are seeing lots of people start to come forward, quite a groundswell and a shift. And then that actually led to politicians themselves coming forward, similar to what Sophie was speaking about, having the confidence to come and say that they are one of the 1 in 9 women that has endometriosis, and they want change. Those politicians then started to talk weekly in Parliament, and I think that made our job a lot easier.
Thank you, Sylvie. Thank you, Sophie, and thank you also to you, Jacqueline. Is there one question that we really need to get on board now? Then please raise the hand here in the room, or is there some questions or remarks? No, you are all very aware about the time frame. That is so helpful for me. I don't like to be the cheap whip, but I kind of have. Was there one? Are you? Oh yeah, that's a long throw. Whoopsie.
Adrian Brown from the UK, and actually I'm on the Open Committee in the UK. Fantastic talks around stigma. I'm interested around the dual aspect of stigma in all 3 conditions, around people being impacted by mental health, HIV, endometriosis, but also living with obesity. And how do we approach the dual aspect in a policymaker where you've clearly done amazing things in your own areas? How do we therefore take that forward to actually help individuals that are impacted by multiple stigmas?
That's a very relevant question, and especially to understand also the complexity of comorbidity. Yep, because it only adds up. Who of you brilliant ladies have a take on this?
Yeah, I can just go.
Yes?
Yeah.
Yes, please, Jacqueline.
We've seen that, especially like, for example, in HIV, we've seen very many people having issues. For example, gain of weight, other issues that come around taking HIV. And the stigma around HIV, there are many things. There's the self-stigma and the stigma by others. You find yourself that, before other people get to talk about HIV, you yourself as a person living with HIV, you're already stigmatizing yourself. So when it comes to spaces, we've moved, like, for example, we have an opportunity of having the issues of persons living with HIV being incorporated in very many documents, but we still have the fear that it's not an issue to be talked about. So there's a lot of advocacy groups that have come up to see that, the issues come all the way from community. Sorry, I'm bringing in the community because this is what I represent. And when we talk about persons living with HIV, you'll find them everywhere. But the community of people living with HIV has the voices themselves. So it's very important to have the voices to be able to have the right messaging in terms of also fighting stigma. I don't know if I'm being clear, but one thing you need to note is that when we are talking about, for example, HIV, the obesity is something that has always been a discussion because there are a lot of things that have come with the HIV medication and HIV treatment, as we can say it. And one of them is obesity. But we don't actually bring in obesity because there are very many issues that actually people say, oh, we don't need to talk about. But HIV, you have HIV, you're already facing obesity. You're already experiencing stigma. This is what we are going through, like the global, like people living with HIV, they're expressing the 3 things altogether, even more than 3 things. So it's very important when we are coming up, we're talking about HIV, let's talk about obesity. Let's also find a way of fighting stigma because it's a very big issue. And you can't just fight one, you need to have the 3 move together. Exactly. HIV, obesity, and stigma. And then we can be a free world that is happy.
Joe, let's make that a world for all of us, but also to make politicians not be afraid of stigma, because that's actually what I learned as being a politician. Now, there are a lot of colleagues that are being warned not to engage in certain areas where they are already stigmas, and by then avoiding to go in to this field of conversations and challenges, we slow down the speed of political change that are really needed and also asked. So thank you so much again. Thank you so much. Now it's time to draw the conclusions. What can we learn? And I would like to welcome on the stage obesity experts, all of you. Dr. Avram Karasik from Open Israel, please take a seat. And Jacqueline, please enjoy to be now a part of the audience. And then Melanie Balke from Germany. You are a patient representative from the German Adiposis Alliance. And the last, where are you? Oh, you are there. Professor Gnesi, Professor of Applied Medical Sciences, endocrinologist and member of Open Italy.
Thank you very much for the presentation.
I have I'm trying to make my tongue do the right things. Coming from Denmark, it's not the most easiest task, but anyway, I'm delighted to see you now in the panel, and we have heard a lot of good advice and experience from other patient groups. So I would like to just give you all the same question, and I hope to hear 3 individual but fruitful as a bouquet answers back on how you address the similar challenges that we have just heard about being discussed, but also the efforts being made in your countries that we can use going forward, helping each other to improve on obesity. Professor Gnocchi?
Okay, so in Italy was, let's say, a long and winding road, the road that we followed in order to obtain, first of all, the recognition from the Italian Parliament of the obesity as a chronic disease. This was the first step. In order to achieve this, we did a teamwork that was realized by a number of different organizations. There were academic organizations that are crucial. There were patients organizations. There were contacts with the politicians that was extremely important in order to achieve our goal. And through this, we obtained this result. But I think that the main way to obtain this kind of results, we need a lot of many other improvement in this field, is the strength of the knowledge to communicate well with what we know we define as evidence-based scientific results, as I heard before by the other speakers. And this is, to me, is really crucial. And another important thing is to have only one voice. For example, in Italy, we had one scientific society, that is the Italian Society of Obesity, that was the leader of this group of people, and this is in this way is much easier to obtain the attention by the government. There are also many other efforts we did, like, for example, television spot, articles, congresses and meetings, both at national level but also at local level. This was the main thing we did. And the next step will be the recognition not only of obesity as a chronic disease, but also the inclusion of obesity in the so-called, in Italian we call this LEA, that's L-E-A. It is an acronym that means essential levels of assistance. This is crucial because it means that is charged to the national health system. the interventions are charged to the national, and for obesity is easier in some way than in comparison with the other diseases because of the prevalence. It is so enormous, the prevalence of obesity, that also for economical point of view, very often the government are sensible to this kind of approach. That's all, more or less, in brief.
Yeah, but it's wonderful.
In brief.
Brief presentations are always welcome. So knowledge and
knowledge is crucial.
Knowledge is crucial, but also speaking with one voice. That was also
Yes.
the message from Sylvia from Australia. Now, Melanie, what is your take on the question?
I think for me as a patient and for Germany, that we always have is trust. They trust everyone in the whole open, and that was, my doctors knows me very well for a long time, and they know I make not a fail. We learn together, and for this we have trust, we have empathy, and for this we can change so many. We can speak together. Sometimes we call it as friends. We're growing as a family. And when you are a family, you do better work than you are in a factory or something. And that is something you must find the right people to can work together. That is not you take a piece of this, you pick a piece of this and put it together. Yes, it works. It works a slow part. But what obesity need is a very much longer way. And we must stay together. And what I learned from work together with other patients, and normally I was born and I was Melanie. And then I was grown up and I was a fail. I was a fail in the system. Nobody have trust in me. And then they say, I'm a patient. No, I'm not a patient. I'm a people living with obesity, and I'm a people first. I'm Melanie, and I like to invite you that ribbons, pick it up, put it on, and think, every people with obesity is a human being with a heart and with empathy. Go to the ECPO booth, take it, and meet a patient advocate.
Thank you so much, Melanie. We will absolutely do so. But also by hearing, listening to your personal story, and also that you allow yourself to be you, and also show the emotions that comes with being you. You also share with us and give us hope and courage to be that also ourselves. Because a lot of politicians maybe should be just as brave as you are, saying as an introduction to a conversation on obesity that I'm afraid to talk about it because I don't know how to talk with you about it. That could really be an icebreaker that I think we should support much, much more.
It's something that I do. Give me the opportunity to walk 6 days with a politician in Germany.
Yeah.
And I'm very afraid. He looks at me and he was so slim and I was so big. And I think, oh God, what he must think. And yes, we go have a dinner. Everyone needs to eat. That's not fair. And they say, come on, we walk. And normally I take a taxi. Yeah. And I say, okay. He said, hey, it's a small one. And it's okay. I try. He was in 5 minutes and I walk 15. And it was raining and I was wet. And he said, what you doing? I said, I walk. That's living with obesity.
Yeah.
And for this, he starts to think. He see in the morning the chairs that is not possible for me to sit. And he stand up earlier and look for a seat for me. And this is how the magic, the magic of people.
Yeah, that is when empathy
Yeah.
it becomes neighbor love.
Yes, that is.
It's all it takes.
Us. This is not us. You all us.
Yeah.
You are all a part.
Thank you. We come back to you, Melanie. Now, Dr. Karasik, what is your take? And start?
First of all, I'm very impressed with all the work and that I heard here, and also Melanie's words. But I would like to stress the fact that in Israel, we were able to take it one step further. Everything that was described also in Italy and also as far as describing disease and still needs a lot of work and is important. But I think we should tell the politician what to do. And there was a campaign about giving taxes on sweet drinks, which is nice. It was levied, but usually the money is taken by the Ministry of Finance to the big pot. We insisted that it will be given to obesity, to obesity therapy, and we were able to get it for this year, the first payment. So, and we gave them a plan what to do with this money in 2022. Yes. So the idea is the politician, if you just come, of course, you have to create the atmosphere. You have to address the people points. All this is the basis, but you must also take the next step, and this translation to tell the politician what to do. The politicians don't know what to do. They can sympathize, and it's nice, and it's important. It's critical in the prioritization. But we, as the professionals and as open, I guess, should encourage a plan. What do we want to have? If we don't know what to do, they will not give us the money for it. They don't understand words. They say, okay, in this budget, we'll get, if you show us that it's helpful, next year, we'll put it in the base of the budget. And that's what we are working on. If I would have more time, I would tell you what is the exact plan and program. I'd like to do it afterwards, also if you want to hear. But that's the point. The point is, and indeed, we took all the scientific councils, set together, set up a white paper, translated into a decree. The decree goes to the Ministry of Health, and the Ministry of Health adopts it. So I think my message is that if whatever I heard here was very inspiring, and especially Melanie's words and the cry from the people living with obesity that they are neglected and not. But then we, as physicians, and as a professional organization, said, okay, so what are we doing? And the politician will listen to us because politicians are now aware. And I must admit, we are also at a place, and that's we cannot look the other way, where there is a medical revolution because a new medication that came on offer or promise some. So all this creates an atmosphere. Politicians are ready. Let's give them a plan.
In Israel, is obesity acknowledged as a non-communicable disease?
It is acknowledged by the medical staff. It's not acknowledged by the government. But that's not the point. The point is when we came to Dror Dicker, who should have been here, he went to the Knesset, to the Israeli Parliament, and he met together with people from the Ministry of Health. They sat there and said, "Look, this money, not only are you going to levy the tax, but you're going to give it to us, and we'll tell you what to do with it."
So you were actually designing the ecosystem of how to act.
The whole system. We did it, and another thing is, it's not obesity experts because obesity experts are weak. Well, I mean, I'm talking about myself. The strong people are the cardiologist, the gastroenterologist, the family physician, the psychiatrist. Gather them all together because obesity is not a disease of a profession of obesitologist. It's something that is common to everybody. And that was the point. That was the point. And you take family physician, gastroenterologist, cardiologist, psychiatrist, and everybody contributes it, and then you have one point, one voice, which belongs to all. But that's not the point. The main point is, in every country, decide what you want. What you want.
Exactly.
What you want.
So what you also is telling to the EU countries, make a national plan for how to address and to work with obesity.
Exactly.
And I can promise you and Melanie and also Dr. Gnessi, Professor Gnessi, and also all of you that we in the MAP interest group for obesity and health resilience, together with Jacqueline and her great team of VA, so we will take that on the agenda as soon as possible, because either we make the national governments to accept such a fact that obesity is a non-communicable disease. That's the one door that they can start by going in, or they can sit down together with us and with the good examples from abroad, how to make a national plan. And then we see how the national plans of every European country adds up to the fact.
I just want to mention once again, the levels of, there are a lot of work to do in cognition, in explaining what Melanie underlined, and a lot of recognition of disease. But that's the stepping stones towards action.
Exactly. Thank you. And for the last remark, yes.
If I can add an actor to the team that I forgot before, is the world of the pharmaceutical companies that contributed to what we did in Italy. And the other thing that I would like to do is that is crucial to me, the insertion of the culture of obesity in the educational programs, in the health professional schools, for medical school, but also nurses and so on. I am old enough to remember that when I studied medicine, in the internal medicine textbook, there were 2 or 3 pages about obesity, but the science go ahead. There is a lot of more things that we know now, and so it's crucial that the argument will be treated in the educational programs.
Exactly. Also because obesity is actually the core root of more than 200 different diagnoses that we do pay attention to, and that we also address with a lot of money and concern. So let's go to the roots together and make the plans that work in every national country in Europe, but also as a leading example as EU, we can, together with the rest of the world, thank you, Sylvia, thank you, Jacqueline, we can also share with each other best practices that maybe you can use in the HIV and that you can use in Australia in the endometriosis. Thank you so much. I hope it made sense at the screens to follow this event. I know I'm a politician. I'm not a journalist. My daughter is, so I'm not a professional coach of doing this. But I hope that you all felt welcomed, and that also the fruitful debate and points coming from everywhere almost in the world was contributing to the rest of your day here or at your seats following this very important conference on obesity. Thank you so much. Sorry for calling you Gnocchi.